Good morning, everybody. We are going to get started. It's the top of the hour. And as we do that, I'm going to scroll through some disclaimer slides. Please be aware that this session will be recorded and made available through the Asthma 411 and Cook Children's website to share publicly with others. We welcome everyone on behalf of the Asthma 411 initiative, and we're so glad you are able to take time out of your day to join us for this in-service. I am Courtney Bernard with the Center for Community Health at Cook Children's, and we are happy to be a partner on the Asthma 411 Consortium, along with Safer Care Texas and UNT Health Science Center, JPS Health Network, and Acclaimed Physician Group, and all of you within Tarrant County School Districts. Our goal for today is to provide timely and relevant continuing education for the school health staff who participate in Asthma 411 here in North Texas. But we've also opened this in-service up to other school districts and nurses around North Texas or Texas overall. I see we have plenty of registrants from all across the state and even outside of Texas. We've also opened it to teachers, coaches, and school administrators to hear this information. So today we welcome presentations by Dr. Daniel Guzman, Rebecca Delacio Basley to recognize asthma emergencies at school. Then we'll close with a few Asthma 411 program updates from Dr. Leslie Alsop. Before we get started, we wanted to make sure everyone had the chance to sign in as you logged into the webcast. After today's session, you will receive an email to complete an evaluation. Completing this evaluation is required to receive the 1 hour of nursing continuing education credits, but we welcome feedback from everyone through this survey. As I said, the session is being recorded and it will be posted online in a few weeks for viewing and CE credits through the end of 2025. The recording and CE link will be searchable on our websites, and we'll send out a notification to the emails we have on file. So I'd now like to introduce our two speakers, Dr. Daniel Guzman and Rebecca Delacio Basley. Dr. Guzman is a pediatric emergency physician at Cook Children's Medical Center and has been on staff since 2003. He is passionate about injury prevention and currently holds the position of medical director with the Center for Community Health as an advocate for educating our community about all injury prevention topics. In 2017, he started AIM for Safety, a firearm awareness program focused on reducing the number of unintentional firearm injuries seen in children. He's currently spearheading the creation of a hospital violence intervention program in collaboration with JPS Health System, Texas Health Fort Worth, Cook Children's Healthcare System, targeting firearm violence in Tarrant County. He is also the medical director for the Teddy Bear Transport Team and serves on multiple committees at Cook Children's, including the Hospital Quality Improvement Committee, the Trauma Improvement Committee as Associate Director of ED Trauma Services, as well as a liaison for the Surgical Clinical Excellence Committee. And if that was not enough, he is the executive member and secretary of the Emergency Physicians Advisory Board that provides medical direction to MedStar and surrounding EMS agencies, and serves as the co-medical director for the North Central Texas Trauma Regional Advisory Council, providing direction and development of protocols for the hospitals in the region. And lastly, he provides education and training for medical students from both TCU School of Medicine and UNT Health Science Center. So Dr. Guzman is committed to not only keeping children safe and healthy through the emergency room, but really giving back to the community. So he brings a great perspective today. Rebecca Delacio Basley is a registered nurse. She has been a nurse for over 30 years, with more than half of those in the school setting. Prior to the school setting, she has experience in med-surg and telemetry, case management, home health, and hospice. In the schools, she has worked with middle school students before joining Northwest ISD as the district's health services coordinator. Rebecca's interest in business models had influenced her desire to help streamline clinic processes and ensure compliance with state guidelines. Through Northwest ISD's partnership with Asthma 411, she hopes to further improve the lives of students with asthma and to apply similar methods towards management of other chronic conditions. So I'm glad we've got Dr. Guzman and Rebecca pairing up to give you guys some great information today. We have set aside time for questions and answers at the end, so please feel free to add your questions in the chat box along the way, and I will read your questions out for Dr. Guzman and Rebecca to address at the end. So before I hand it over, I want to make sure we get to know who all of you are in the audience. So if you would please, in the chat box, introduce yourself, share your name, your organization, if you're a nurse or maybe some other job role, and where geographically you're coming from. Like I said, we have folks joining all across the state of Texas and beyond here today. But with that, I am going to hand it over.
All right, here we go. Hey guys, good morning. Appreciate y'all's time today in this, I think, very important discussion. We would all agree that affects so many people in our country, but definitely in our schools. So I want to give you guys a ER perspective on how I do this and what I do on a daily basis in being able to find those kids who are struggling more so and try to intervene before they get to that point where we're having to call 911 and kind of escalate care. And I appreciate Rebecca being here today as well. I think she's going to provide a great perspective that I can't give because I don't do what you guys do. And I think it's definitely, when we look at how we treat these patients, it's definitely a team concept, right? From what, definitely at home and being able to help parents understand the importance of their children's symptoms and their diagnoses to how that translates to making sure that the school understands that and then the school knows about those conditions for y'all to be able to help them. And then obviously that helps me in the end when they ultimately reach my doors. Next slide. And so as we talked about earlier, at least Courtney did, about what we want to accomplish, what our goals are today. I really want to kind of get back to basics of asthma, and you guys probably all know all about asthma. You guys deal with it every single day, but definitely want to give a very basic view of what it is, so that anyone out there, no matter what your comfort level is, you can identify something that not making a diagnosis of asthma, it's making a diagnosis of, or at least addressing and finding those children who are having trouble when they can't come out and tell you that innately. So I think that's going to be the important part. When you think about what asthma is, it's a chronic respiratory condition. It's caused by, a variety of inflammatory triggers that cause, this airway edema that ultimately narrows the airway, and that's where the problem becomes, right? That's when we start seeing those kids who are having more and more trouble. Definitely frightening and definitely deadly. This is something that it unfortunately happens around the country. Over 3,000 individuals die every year as a result of asthma. So we need to be aware of kind of those subtle signs and symptoms. Also be able to stay calm in those situations. I think we all get frightened, no matter who you are, even after doing this for 25 plus years. There's always a part of me that's always not necessarily afraid, but aware of what's coming through the door, right? And I think that keeps us on our game, that keeps us sharp, so that we don't become complacent. And I think that's one of the things that I always impart on medical students. Complacency kills. If we become complacent about what Johnny or Joan has, and their symptoms today are not so severe, one day that may lead to a more severe event that definitely can cause a tragedy. So we want to be aware of those. Definitely is a leading cause of ER visits and hospitalizations that we see here in Tarrant County, but throughout the country as well. And the cost is well over $80 billion. And that's, related to medical care, missed school, missed work, all those things that go into, taking care of these individuals. Next slide. when you look at how many Americans are suffering from asthma, there's over 25 million Americans in this country that suffer from asthma. 1 out of every 11 U.S. children from the ages of 0 to 17 have asthma or have been diagnosed with asthma. So I think that's really important for us to realize that it's really out there. And a lot of you know that and see that on a daily basis. Unfortunately, it disproportionately affects our minorities and our socioeconomically disadvantaged children. Black children have the highest morbidity as well as mortality rates. And you'll see that there's more than 2 times the ER visits and 9 times the mortality rate versus white children. And so that's pretty significant, depending on what part of town you may be and how important it is to, I think, ultimately provide some perspective to parents and help them and understand having those asthma action plans becomes really important as well. And being able to help them and guide them into how important it is that we take this seriously on a daily basis. One of the things that I like to highlight a lot of is kind of the misuse of inhalers. Those little puffers that people use, and a lot of times I'll see kids that come into the ER who aren't using a spacer. So I will highlight that a little bit later, how important I think that is, and the education of teaching the kids how important, even though it's cumbersome to carry around a spacer, how important that really is to maximizing their care and maximizing the ability of that medication to do its job ultimately. Next slide. When you think about what asthma is, it's an immune-related mediated response, and it is an inflammatory disease that can be triggered by a lot of different things, as we all know. But that triggering process can cause a sustained immune response in our bodies. And from that standpoint, our body's immune system is just basically overreacting to whatever trigger that is. And for asthma, it's affecting those lung small airways. And so you look at, this is definitely can be intermittent, definitely reversible. We know that, right? We can intervene to help improve that. But there's also other things that are needed along the way that improve and help stabilize that condition. And again, triggers are the most important thing. I think we need to be able to identify triggers, be certain days to know that some will suffer more than others. Respond to that and have a plan, which ultimately is I think in my mind, always having a plan is important. That's in the ER, you never know what's going to go through the door, but you have to be ready to respond and have a plan, thinking 2 or 3 steps ahead. I think that's really important to know that I'm doing this, but what am I going to have to look for? What am I going to do? What's the next step if this doesn't work, or if this does work? And you're definitely going to be following your asthma action plans and your asthma 411 guidelines, but you also want to be prepared for that so that no one's panicking. I think that's really key in these situations, is no one's panicking, and that as the medical professionals in the room, or even the school professionals, that we're taking control of the situation and help managing, as opposed to creating more chaos in these types of situations. When you looked at asthma, there's 3 types. You have this transient early wheezing, and that usually resolves by the age of 3. It's not really associated with any family history. There's a positive association with prematurity, and it usually, you'll see kids that are exposure to daycare that suffer from this. There's also some association with transient early wheezing and maternal smoking as well. So it's important to know. When we look at our non-atopic wheezing, these are the kids who I see a lot of this time of the year, and it related to RSV and viral infections, and that typically is that wheezing that resolves by the time they're 3 or 4 years of age. But there's some evidence that if you had RSV young and you're wheezing, that you may have asthma-like symptoms and asthma later in life. So also important to note. And then finally, there's the bad wheezing that we all see, the bad asthma, the atopic wheezing, which there is a family history. There's definitely early allergen desensitization that can cause more problems. And then there's also a genetic predisposition to this type of asthma. Next slide. So I like to throw kind of fun tidbits of information. We want to learn, obviously medical stuff, but there's also time to add something in here that some people may not have, and you can try to stump your children later today. But the first question is, which animal has the most lungs? Is it A, spiders, B, elephants, blue whales, G, salamanders, or E, snakes? And if someone wants to throw that in the chat, you guys can definitely do that. Give you guys a few seconds to figure out what y'all think it is. There's a delay, so we're going to wait. All right, we'll wait a second.
Okay, looks like we have C, multiple C's.
Excellent.
We have one A. We have a D.
And a D. All right. Next, so go hit the next button there, recording. The answer is spiders. You can hit it again, and so spiders have to have either up to 2 to 4 pairs of lungs, or kind of stacked like a book, and so it provides efficiency for them to be able to breathe. And so I thought that was really interesting. They have just as many eyes and legs and lungs as they do, right? Elephants, blue whales obviously have one of the largest set of lungs that there is out there, and salamanders have a different way of, in some cases, actually providing oxygen to their system, more of a peripheral through the skin type of gaining of the oxygen. Next slide. So to give another perspective of asthma and how it relates to other things that we may see in the office, in the clinics, at home, and or something like croup, bronchiolitis, and asthma. They all kind of can present the same way. Croup obviously is a little bit different, but I hear a lot of families telling me, oh, my child's been wheezing overnight, and they walk in through the door and they're actually having stridor, which is different. So being able to kind of help families understand the difference between the two and what's what, but for ourselves as well, sometimes it can be really difficult. Some of these kids can be really hard to kind of tell wheeze from asthma, especially, or wheeze from croup and stridor in the younger group, and it can be really difficult for me sometimes as well, especially when they're crying and they have lots of upper airway congestion. But you can see that all of them, their etiology is typically viral, with the exception of asthma. Right? There's other things that can trigger that, not necessarily a viral illness like RSV or influenza, but there's the environmental factors that can affect that, the allergens, the pollutants in the air that will make a difference. And in many cases, these kids won't have fever, right? Asthma kids, when they come through the door, they're not running a fever unless they have this concomitant viral infection that's triggering that. But in many cases, they won't. So definitely a way to kind of tease them out as you're looking at the children in front of you. As you look at other key features, croup is going to have a barking cough. They're going to have inspiratory stridor, which is more of an upper airway disease as opposed to a lower lung airway disease like asthma and even bronchiolitis. And then the treatment is definitely vastly different. Ultimately, for both croup and asthma, we use steroids, and in a lot of cases, bronchiolitis, there's no supporting evidence that steroids are going to make a difference in that subset of population of kids. And occasionally, if there's a strong family history of asthma and ATB, then I will potentially give an albuterol nebulized treatments to some of these broncholytics, although many of them don't respond, but it can sometimes make a small difference in those cases. So you can kind of see the general difference of what these three that we most commonly see in kind of the age group of a couple of months to up to 6 and 7 years of age. We as adults still get RSV, and I've heard this past winter and late in the summertime, adults were getting RSV, and it's one of the most uncomfortable and long standing disease that they've had in a while, not realizing they had RSV, and so RSV can definitely be a player for a lot of us in many different ways. Next slide. And so triggers, I think this is really important. Rebecca and I think, are going to really impress upon everyone that this is what can make asthma worse, right? When we look at what's going on, there are different types of triggers out there that can affect our patients and our students. Allergen and irritants are definitely at the top of the list, as well as the outdoor and indoor type of irritants and allergens that affect them. But everyone is different. Each one of these, students and patients with asthma is going to present differently, and their triggers are going to be different. One might, have a trigger that's more cold air versus the chemical fumes. Unfortunately, cats are one of the highest allergens that from an animal standpoint that we have, and so if they have cats at home, that's going to definitely trigger them. Others, as you look into our school age or teenage population, exercise-induced asthma becomes a bigger problem as well. But we also have to stress, and this is what Healthy Homes does, is stressing those things at home that include animal, pet dander, bugs in the home, pollen, fumes that may be affecting strong odors, all of these things. And I think one of the biggest things that people don't realize, or they do, but it's a hard habit to break, is smoking, right? I think I smell that a lot on families who come in with their kids with asthma, and trying to reinforce how important that is, that, even though you smoke outside, even though you use a jacket, if someone else can smell it in that room, imagine what those little lungs are going through and how they're responding to that. So it's really important they understand that, and understand that smoking is not an easy thing to get away from. It's not, it's an addiction to a large extent, and it's hard to stop that habit. But it is also affecting our children every single day, and I think one of the main reasons why we see so many kids. Next slide. And so what are the different types of allergens? We all know about the pollens, trees, and grasses. The dust mites are important that we talk about, pests around the home. Unfortunately, our animals, and no one wants to get rid of the animals, but, it's really important to kind of research the kind of animal you may be getting and bringing into your home. I know for us, we have a hairless cat because my children are extremely allergic to lots of things. And so we have a hairless cat that looks really funny, but it really helps to um, decrease the number of episodes they have daily. But also, I never thought hairless cats would be dirty, but they're really dirty animals. They don't. So, but also, you think about foods and molds as well that can also be allergens. When you look at irritants, there's so many in the world, right? We look around. Pollution, weather changes can cause lots of symptoms. That's when we see a large increase that I'm going to work the next couple of days. So I suspect that, when we start to get this cold weather in, we're going to start to see a lot more kids coming in with asthma-like symptoms as a result of that, and asthma rather. But also illnesses, cleaning agents. I think that's really big. We're all trying to keep our schools clean. We're all, wiping down everything we can. But those same agents can also affect, especially if they have a really strong odor to them. We know about smoke. Exercise can be one of those. Medications can sometimes cause that as well. Again, looking just at, personal care products, lab chemicals, anything around the school. And I think this is really important, that, you establish in your schools where those places that some of these irritants could be, so that you're prepared and you can help to manage those rooms to, I think, most of uh, keep our kids from obviously becoming ill, and keep learning and not at home or in the ER as well. Rebecca, do you have anything to add on triggers?
Definitely as a former middle school nurse, just the overwhelming use of body sprays and perfumes at that age, when young people start to realize that they do have body odor. Definitely in the school setting, we are trying to keep kids healthy, as you said, and we're doing a lot of deep cleaning right now due to flu season. But sometimes people go overboard with the deodorizers and sprays and things in the rooms, and then you walk in on Monday and it's kind of like a cloud of Lysol. Although we appreciate it, and definitely our custodians are working hard to keep us healthy, and our teachers are working hard to make the classrooms very warm and cozy and appealing. The use of candles and wax melts and plug-ins and things like that to make the room more appealing also sometimes trigger asthma in the school setting. So there's just a very long list of triggers and irritants in the school setting.
Yeah, definitely challenging. I mean, it's a tough place to be. You guys are expected to do a lot of different things, and I think it can be really difficult for y'all in the school to obviously and it'd be challenging to do all these things and keep kids safe at the same time. Next slide. So I think it's really important to have a plan, right? My life is all about plans. My kids, are always like, "Well, I can't do this because you're going to say this is going to happen to me." I'm like, "I've seen it all. It's just part of life." But I think it's there's certain situations like I talk with our transport teddy bear teams is, before you get somewhere, have a plan of what you're going to do and how you're going to respond if something goes sideways. And if as you start to provide care, think 2 and 3 steps ahead, like we talked about earlier. You always got to be prepared for what's gonna happen. I think in school is no different. This is an important thing. It seems trivial and small, but I think preparing each day, each week of what's the weather going to be like. Is this one of those red warning weather days, and is it a pollution day, and or obviously you guys are seeing lots of flu like I am. You're dealing with all of these factors, but having a plan, knowing what's going on, so that on those occasions like tomorrow and Wednesday and Thursday, when you see somebody who looks just a little off, who may be coughing a little bit more, who just doesn't look right, and you can say, hey, maybe this is something going on. Maybe this is asthma. Maybe this is a reactive airway component to what's going on. Have that in the back of your mind and not just assume, it's the flu, no big deal. Let's let Johnny go back to PE or whatever the case may be. And so I think these are all important things that we all should be doing for the safety of the children, and just overall being able to plan and be prepared ultimately. Next slide. So what are you going to be looking for? I think this is really important to know what to look for. In many cases, when I walk into a room in the ER, before I even approach a child, a lot of times I'm just looking. I'm just, eyeballs on a child, going, okay, what are they doing? How do they look? What's their respiratory rate? Are they breathing really hard? Can you see their kind of their ribs kind of popping in and out? Are they having some nasal flaring? Do you see that little notch on their kind of in their throat, kind of depressed a little bit? Are they able to speak to you? Do they just look tired and pale? I think these are all little things. You guys know your kids really well. And so you're going to be able to pick up on these little cues, I think. You just have to be aware that those are little cues related to potentially asthma, and know that, gosh, this kid's struggling. When asthma is one of the largest leading causes of absenteeism in our schools, right? So we have to be aware of these things, and if we have a school-based management program in place, then there's going to be help for you. But I think it's identifying who is sick to be able to go to the next step is really going to be important. And then what are you listening for? Again, I'm listening for, before I even put a stethoscope on a child, is can you hear them audibly wheezing? Are they coughing significantly and they can't stop? Is there any kind of irregular pattern to what they're breathing? And then obviously those abnormal breath sounds that you can hear. Sometimes wheezing just comes from the nose, and if the kid's really has a lot of mucus in his upper airway structures, and you're going to hear a lot of that wheezing and what we call rhonchi as well throughout. And then you'll see some of these kids who are just having this prolonged expiration, where they take their breath in, but they just breathe. They're breathing out for almost 2 times the amount of what they're breathing in. And that's going to be important. So all these little subtle things to look and listen for. Next slide. And then ultimately, what to do. I think number one, stay calm. I think we all need to stay calm. We can get excited in the ER. When somebody comes in, everyone's rushing to do different tasks that they have. But I think most importantly, is there needs to be someone who's in charge, who's staying calm in that situation, reviewing the asthma action plan, right? Reviewing if they have something on file, that we're looking at that. And I think Rebecca and I talked about, a lot of y'all know who those kids are who walk through the doors, and you're like, oh, there he is. I know what's going on. But in some cases, you may not have that asthma action plan, or even this child maybe or student has never even come to your doors prior, and this is all of a new onset type deal. So you have to be kind of prepared for that. I think making sure that the student's sitting upright and checking their breathing. If you have a peak flow, that I think that can be helpful as well. And then, whether it's an assigned or unassigned medication, you start to do your treatment at that point. And then you reassure the student, keep them calm, keep yourself calm on the inside. I always talk about reassessing, reassessing, reassessing. That's really important that we're doing as often as we can. Every few minutes, every 5 to 10 minutes, that you're reassessing these children. Using, pulse ox as well can be important. But like I talk with my families, I always say, if you have a pulse ox at home, let's not just concentrate on the number. Let's concentrate on the global patient as well. So you're looking at their respiratory status. You're looking at and listening for what they sound like. You're obviously using a pulse ox, or if you're using peak flows, you're using all of these together to build a picture as to how you're going to respond and where you think you are in that child's care. Are they green, yellow, red? Do we need to go now, or do we have some time to try some of this medication in the office and in the nurse's office? So these are all things that are really important. And then obviously, if you have no change, calling parents is important. You guys already know that. And then 911. I think if you have multiple you have multiple people who can be helpful in that situation, whether it's a teacher, an administrator, they can be doing that while you're continuing to treat the patient. And then always, obviously the spacer is really important. Next slide. So when to seek immediate care? When should you turn up the volume on what's going on in front of you? I think that's really important. You got to know when to say it's time to run, it's time to go. And so when I see a kid who comes into the ER who's unable to speak to me in complete sentences, is giving me one-word answers, he's obviously potentially gray, blue, cyanotic. He's got severe retractions, and you can see that rib cage, in and out. He's flaring. I don't always do peak flows in the office or in the ER. Obviously, that's not something that we typically do, but that can be important in some of these kids, especially if you're not sure what's going on. But again, that's time. So it's all kind of putting it all in perspective and knowing, okay, this is more important. I should be looking at this, or what I'm seeing in front of me necessitates action now, which means calling 911. And then, obviously in the interim, doing what you guys do, whether you're following the asthma 411 guidelines or the patient's asthma action plan. Next slide. So what are the risk factors for death for asthma, in asthma at least? So those kids, and again, hopefully you guys may not always know this. I don't always know this when somebody walks to the door and we're initially starting to work on these children. But if they've had severe exacerbations in the past where they've had to have to be intubated, which is basically a tube down through their lungs to assist their ventilation, any kind of ICU admissions definitely can increase your risk for acute death. More than 2 hospitalizations in the last year, more than 3 ER visits as well in the last year, all are going to be things that will increase your risk for death. Now, there's also all these other things that you can look at on this page that we hope we can educate our families. But if you notice, someone's using 2 canisters a month of their short-acting bronchodilator and that they brought to you, then I think it's our due diligence to start to find out more about their asthma, or their reactive airway, or their wheezing, and really reach out to parents to start discussing, okay, what's going on? What can we do to help? And I know we task y'all a lot with a lot of different things to do, and that's not always fair. I think this is one of those that reaching out maybe even to their pediatrician to help in that, or helping them to find a pediatrician. Again, you guys have ways to do that within the schools and some of these ISDs, and so I think that's an important thing. And then there may be those who just don't understand what they're dealing with in front of them, that just and how severe. I definitely get folks who feel like, oh, this is no big deal. I do it all the time at home, and they feel comfortable with where they're at, but their asthma, on a scale of 1 to 10 is 10. They think it's a 2, and so helping them understand in that perspective, I think, is really important as well. Rebecca, you have anything to add on this slide?
I think we talked a little bit about the importance of maybe just getting the input from the team. It is invaluable when teachers and coaches come to the school nurse and say, hey, this is not the student's norm. So that's the type of information that when we work as a team, we are more effective in helping the student be safe at school. So one, making sure that they know the signs of an asthma attack, a severe asthma attack, and two, making sure that they know the signs that are not an asthma attack, but maybe just deconditioning or other things that happen when students aren't necessarily their norm, so that we know kind of what direction to go in. I think that I'm very happy that we have teachers and coaches on this podcast today, so that we can make sure that we all work as a team to prevent this very scenario that we're looking at right here on the board.
Yeah, I think it's really important. I think and I think this what we're trying to teach today is not kind of basic level asthma, so that we all can identify what it is, or at least know, who needs to be referred to the office, who needs more help. I think Rebecca said it great. It's not their norm, right? They're doing something different than they normally do is really key. But we have to be in tune with that, right? We have to know about that. We have to know that this could be a symptom of something that we need to address. There's so many different things going on with our kids and our kids' lives. I have a 15, 13, and a 10-year-old. I'm right in the thick of it right now. And so we have to be aware of kind of all of these things that could be factors. Emotions can play into some of, an asthma attack as well. But there's also things, depression and suicide, all these other things that we are trying to address and trying to find in a single 8-hour block of time that you guys have these children at school. So next slide. All right, so another interesting question here. Which of the following animals does not have lungs for breathing? Is it a dolphin, a frog, earthworm, or a snake?
Okay, looks like we have C, as we're waiting on other answers. C. They're coming in. Looks like C as the answer for a majority.
All right, you guys
answer.
are good. You guys are on it. D is correct. So earthworms use kind of a cutaneous transfer of oxygen into their bodies. That's why they always have to stay moist and in wet, dark, ground. You can always see those that sit on the concrete with nothing around them are shriveled up and dying. So, if you see an earthworm, put them in the dirt. Next slide. Asthma action plan. So I think this is another important part that Rebecca and I wanted to really stress today, and I think really kind of try to hit this home of how important it is to have asthma action plans. There's here's one from the Asthma and Allergy Foundation of America, but they're personalized written guides on how to manage someone's asthma, and we hope that we're getting these filled out by our pediatricians, our physicians who are taking care of these kids, and providing these to parents to provide to the schools, so that we can maximally provide care for these children. I think that's really important. It obviously tells you when to take medication. If you're doing peak flows, then you're able to at least get some more objective data in many cases to help guide you as to where to go. If you're still not sure and a little uncomfortable with what's in front of you, but it also helps you to recognize this, patients and this students' flare-ups. What are the signs that they typically will present with? Are they just a coughing asthmatic where they cough all day long and they don't show a whole lot until they get really sick? And so I think that's really important to be able to have in front of us. But again, the goal is to prevent the severity of the attacks, right? We want to keep these kids from having to go home or having to come to the ER for escalation in care. So whatever you guys can do to minimize that, that's important. If we can get them through their PCP, that's important, obviously, to help guide these families with any additional treatment plans they need and care and medications that they may need to be on. And when you look at, kind of an asthma action plan, you're looking at, there in the green, those typically are kids who, are performing at 80 to 100% of their norm. And when you look at how you do a peak flow, you're doing peak flows in general, on a well day where these kids are not having any symptoms, and you kind of see that number. And if you're able to, do that in the office or in the nurse's office, then you're able to kind of gauge that. But it obviously tells you, in the green, we're good to go. Their breathing is good. There's, no coughing. You don't hear any wheezing. If you ask them questions about how they're doing it at home, they're sleeping through the night. Obviously, if they're having trouble playing and working, that takes you into probably the yellow zone and potentially into the red zone. When you look at caution in yellow, most kids, are going to be probably, if you're in the yellow zone, you're probably 50 to 80% of your norm. And so you're having a mild to moderate attack at that point, but that can quickly change. I've seen many kids who go from, they don't look too bad right now, and then 5 minutes later, 10 minutes later, they have significantly changed, and their escalation in care is tremendous. And I've had one or two children die as a result of that. How quickly they can change in front of you, and how quickly you have to respond and catch up. And if you don't, and in some cases, there may not be a lot you can do because things have been going on for a longer time. They didn't identify what was happening before that, or we didn't identify, whoever that may be around them, parents, at school towards the end of the day, and everyone's going home. But all these things can be definitely important for us to look at. And then ultimately the danger zone, right? If you're in the red, you're less than 50% of your norm as far as a peak flow, but also you're in significant distress at that point. You're going to be, hopefully we can all identify that patient and that student where they're, having difficulty breathing, they're breathing fast, they're pale, they may be even blue. All of these things are going to be important. And then your asthma action plan will tell you what to do. Next step, or next slide, rather. And so I think key points that the preventative measures that we can take, we can see that help us to guide us in how to care for a student. There also provides us early intervention, what we can do early on and how we can provide those important parts of what's going to make a child better. They're a good communication tool, and obviously they're a personalized approach. And ultimately, the goal is to keep these children from having to leave school and going to the ER. But if they do, they do, right? That's what we are here to help and manage with that. Next slide. So I'm going to talk a little bit about kind of short-acting treatments, which are the short-acting beta agonists, something like albuterol, Ventolin, ProAir, levoalbuterol as well, that we're all familiar with, and those are typically those little inhalers or nebulized treatments that we are providing to our children who have asthma or wheezing. They're a quick relief. I think the most important part to this is they are quick relief. They are going to provide you and that student improvement, hopefully, during an asthma attack now. They'll usually work within a few minutes to up to 20 minutes. You'll get that effect, and that effect can last a couple, 3 hours or so. And you can see that the cartoon there, you can kind of see that, there's a normal airway on the left, an asthmatic airway. You can kind of see the increase in building of edema that's going on and affecting those small little smooth muscles in our lungs. And then you can see the medicated airway with albuterol or some other short-acting beta agonist. And then you can see kind of it opening. Now, does it completely get better? No, right? I mean, there's other things that we need to do, and steroids become a good treatment regimen as well in these short-term attacks to help improve the child. But again, this is the medication you're going to use if you're experiencing or seeing an attack in front of you. You can also use them before exercise. And I believe that the Asthma 401 guidelines as well talk about that. but they're not daily controlled. This is not something, if you see somebody who's using their albuterol inhaler, or that you're having to use this on a daily basis on a child, on a student, then we need to be doing something different. We need to be able to reach out to their parents and discuss how this is an important factor of their asthma is definitely more severe than we all are recognizing at that point. So they're not long terms. They shouldn't be going through these, on a monthly basis. Next slide. And then you have your long-acting treatments, your controller medications, and these are going to typically be your inhaled your steroids. And then you're also going to have some long-acting beta agonists like salmeterol, formoterol. And then there's even combinations of these as well that are out there as well and being used. Now, even in that setting, I spoke with our pulmonology chair at Cook, and we discussed kind of the use of these kind of combination medications in a short-acting attack, and we still recognize that that's probably not the right thing to do. And there's some guidelines out there that talk about the use of these long-acting and steroids, but in the age group that's 4 to 5 and under. They haven't kind of evolved into the older age group. And so we still advocate that if you have a child in front of you, that we should be doing their short-acting beta agonist, and that's the albuterol inhaler or nebulized treatment. So again, these are not immediate relief, and they shouldn't be used during an asthma attack. The guidelines aren't there as of yet to do that. Next slide. And so I also stress that, gosh, we got to use spacers. You can see that this is kind of a depiction of what someone, when they're not using a spacer, where that medication, the vast majority of that medication ends up in their mouth and their oropharynx, and not in the lungs where it needs to be really effective. And how that chamber helps, it helps to disperse that so that you can actually breathe the medication in. And no one is really well coordinated enough to be able to use a spacer or use an MDI without a spacer. So it's really important that we use it. But you can see the significant difference in this depiction of, if you got an inhaler with a chamber, how much more medication you're getting to that to those lungs, which I think makes a huge difference. I think, especially with the doses that we're providing these children on the lower end, that we need to be able to maximize all that's getting to the lungs on those occasions. So this is important. Next slide. Next slide. There we go. And so when to use, I think, short-acting beta agonist, really, pre-exercise. I think if some kids have this exercise-induced wheezing, then 2 puffs prior to exercise 15 minutes are important. You can definitely, if you're in the yellow zone of an asthma action plan, and this can change for different ages and obviously their weights. But 2 to 4 puffs you can be used every 4 to 6 hours as needed for symptoms. And then if you're in the red zone, the asthma 411 guidelines recommend 8 puffs is what you want to do, providing the breath. I believe it's I always forget. 8 puffs of albuterol, each 15 to 30 seconds apart, maybe even up to a minute. I think you're able to maximize all of that medication that's going in, and as you can flood that chamber with too much medication, I think sometimes, and not get the full effect. And so I think there needs to be a good enough spacing of time between each inhaled puff as well. Kind of talk about 8 puffs is equal to 2.5 milligrams of albuterol if you're doing a nebulized treatment. 16 puffs would be equal to 5 milligram, which is where I kind of live in the ER more aggressively. But there, so we have to maximize what we're giving, since we're giving smaller doses, by making sure that we're using those spacers. I think that's really key to be able to maximize the amount of medication getting to the lungs. Next slide. So I think it's my last trivia question for the day. How many spacers do you need to encircle the Earth? And this is, if you know the standard length of a spacer, which is 15 centimeters. And you know the circumference of the Earth, which I had no idea.
Waiting on responses.
So I'll give you all this. So 15 centimeters for the
I
space.
have C.
The length of
I'm sorry,
that, the
E.
circumference of the Earth is 40.
A. D. So we have a variety of answers on this one. D.
Yeah, these are
Looks like D.
correct. Okay, so the answer is, Courtney, can you space it? There you go. 267 million spacers would be needed to encircle the Earth. I just thought that was an interesting fact. Next slide. I know I'm kind of running. So we're going to go over a couple of cases. Rebecca, do you have anything else to add at this point?
I did want to just say one little key thing about all the spacers. Some people out there think a spacer is a spacer is a spacer. So sometimes in the school setting, we'll see that the student has run through their albuterol and now they're using their moms or uncles or grandpas. And so there's an opportunity for us as nurses to educate the family that there are different medications in those different inhalers. So just going back to that, just wanted to say that real quick as far as the spacers, be aware of what your students are carrying around. If you're a teacher or coach, you see them with a different color. Normally the red one is one that we see often in school, but not all spacers are, not all inhalers are the same. So be sure we know what our students are using while they're at school.
Yeah, I think that's a great point. I think it's really important, even if if you don't know the colors of the spacers, which sometimes I get confused on too, it's going up and asking, hey, what do you got there? Which medication is this? I think that can be really important as well, especially if you're just don't have that fund of knowledge about the MDIs, but being clued into what's going on, obviously, right? And I think you guys probably would say that kids should be taking medications without some supervision, right? So if they have a spacer or an MDI they're pulling out of their backpack and using, then we probably should know about that, right? Something's going on there and help. So case number one. So the school was closed last week on Thursday for cleaning due to increased number of flu cases, which we're all seeing. I'm ready for it to be over. The janitorial staff spent the entire weekend cleaning, many areas of the school with kind of professional grade cleaners. And so now it's Monday, everyone's back, and you notice that there's an 8-year-old student who's coughing continuously in your room. You ask him if he's okay, and he replies, yes. He's responding with just kind of one-word answers. So what's your next step? Next slide. So should you A, do a quick assessment? It doesn't matter who you are. If you're the principal, you're the teacher, you're a teacher's aide, you're the school nurse, all of y'all should be able to kind of look at this and say, all right, we need to do something. This is not his norm. This is something different for him. And let's say he doesn't have a history of reactive airway disease or asthma, and he doesn't have an asthma action plan that you know about. What should be those things that we need to do? What should we focus on? Quick assessment. Say, all right, send him on to PE. He's okay. Send him to the nurse or call his. And I'll try to run through these a little bit, but I don't want to cheat this. I'll tell you this. There's one good right answer, and there's a partial good answer, second best, if you will.
Someone submitted in the chat a quick assessment, check pulse oximeter and listen to lungs, and then call the parents.
Yep. So I think, and if you hit the next slide or just the space bar. So a quick assessment, hit it again. Send them to a nurse. So I think, yeah, correct, 100%. Quick assessment. I think, you're doing that 30,000-foot view of, oh my gosh, I see someone who doesn't, is coughing a lot. Is this just a choking episode? Is this, an anaphylactic reaction? Did he get into something that, he shouldn't have? Or is this related to something more in the air, right? We just talked about this is a the room has been sanitized and cleaned. So we're talking about industrial strength cleaners that have odors that could be affecting him. And so I think the most right kind of next step is a quick assessment. Second part of this is you send him to the nurse. I think that's really key, but you don't just send him to the nurse by himself. You send him with somebody. You walk him to the nurse. I think that's really important to keep your eyes on him until he makes it there and he's able to be assessed. If you have the ability, obviously, to do the assessment in the, wherever you're at, that's definitely looking at how he's breathing, definitely listening to his breath sounds, pulse ox. All of these are key ingredients that make our amazing cake in the end that can provide this kid the top-notch care. Can you hit the space bar again, Courtney? And then recognizing his symptoms. What are the symptoms that you guys, from that, quick introduction there, what did you see and hear, right? I think in my mind, there wasn't a lot of, description of difficulty breathing other than he's coughing a lot and he's having trouble speaking in full sentences. Trouble speaking in full sentences is definitely puts him in a category of, in my opinion, red, yellow to red. And so at that point, we should be kind of our antennas are up. We're moving more quickly than we would normally on this patient. Next slide. What do you think caused the exacerbation? I think I kind of already said it. And you can hit the next triggers, right? So the triggers are important and how important for him and for anybody with let's say atopic asthma. And so whether it's the cold weather because it's cold outside, allergies, whether it's an infection, and you can hit the next slide or next button. In his case, environmental probably was the biggest part, right? All those cleaning agents that we've been using and they were using and the cleaners is what probably sparked this. And Rebecca alluded to this earlier as well. And so we need to be aware of that going into this. There may be this more than one child who's suffering and having trouble. Spacebar. And so, obviously going back to all the triggers that could be affecting him in this given scenario. Next slide. And so the treatment plan, quick assessment, you escort them to the nurse's office, you review the student's asthma action plan if there is one available. If not, then we're doing kind of the unassigned albuterol guideline. You treat with a short-acting beta agonist. Pretty simple, but can be very, you can get really uncomfortable in that situation. Really, it can become a nightmare situation really quick. And this is why I think identifying and acting on it sooner and treating every single one of these like it's going to be a moderate to severe asthma, because that's how quickly these kids can progress. They can go from 0 to 100 and shut down in minutes and take it from someone with experience, unfortunately, that this is something that can happen. Next slide. And then obviously your good response, if you provide them some treatments and their peak flows are greater than 80, they're not wheezing, you can definitely reassess and in 3 to 4 hours send them back to school or to class, and then obviously inform their parents. The less the response, the more urgency there is calling 911. Continuing to assess that patient, providing additional treatments. And I think at that point, you're going from 2 puffs every 20 minutes, every 15 to 20 minutes as needed until you get the appropriate response and you get the help that is needed to transport this patient. Next slide. So now you have a 15-year-old female with a history of asthma. So she's got asthma. She's been having some daily symptoms with a recent admission to the hospital. So already, in that first line, we threw a lot at you. We've already been hospitalized. We're having symptoms. We have asthma. So radar should be going, and all our bells and whistles should be going off at this point, because now we could be significantly sick. You're walking by the gym. You see them playing basketball. They're practicing, and you notice her kind of just leaning against the gym wall. She reports she's out of breath, running. Uh, yeah, I'm fine. She's a little pale, but she's barely able to speak without taking a breath. What's your next step? Next slide. again, back to the basics, right? I think I kind of promised that assessment. So these are your choices: quick assessment, send her back to practice, call the nurse, review the asthma action plan, call her parents. I think there's more than one right answer here. There's one wrong answer altogether, right? I think we can all agree that there's one wrong answer in here. And you don't have to wait for answers on this one. Sending her back to practice would be the wrong move at this point, right? She needs a quick assessment. You can hit the space bar. We need a quick assessment. We need to call the nurse. We need to review the asthma action plan, and we need to call her parents. All of those are important. Sending her back to practice, ignoring this, or not, saying that, oh, this is likely just her working out and she's just tired from that. I think we're doing her a disservice. I think every one of these kids who, and again, you guys have a perspective in practice that maybe this is not her norm. This is, you guys have been into the season. We're, 8 weeks into the season. She shouldn't be having this many problems, right? And so I think that's important. Next slide. And then recognizing the symptoms: difficulty breathing, tightness in the chest, not be able to speak. All of these are important. Next slide. And so she states she's got an inhaler in her bag. So she goes ahead and does 2 puffs. And she does it like that little girl in the picture. Wrong, right? I think we all know that that would be the inappropriate way. She begins to have more trouble breathing. So you escort her to the nurse's office. Next slide. What's the next step in her care? So the asthma action plan becomes really important, right? She's got a history. She's been hospitalized. We need to respond to what's on that asthma action plan. We need to be aggressive at this point, I think, and looking at her symptoms and moving more quickly and with some purpose. I think getting some additional help, communicating with school staff, if whoever brought her in can stay, and then perhaps even dialing 911 at this point. Next slide. And then kind of the same thing. If you get a good response from her initial treatment, which you have not, she's still in significant distress. So I'm going to say she's still in a poor response. She's still at of her normal peak flows, and she's in a red danger zone at this point. So we should be really kind of kicking it off at this point. Next slide. So you review the asthma action plan. You give her an additional 4 puffs of her inhaler. Her saturations are 88% in the office. She becomes unresponsive in front of you. What do you guys do? And I'll wait for answers on this one.
While we wait for answers to come in, I did see one person in the chat had said that their district does not have unassigned albuterol, and not many across the state of Texas do. So we might talk about that as we wrap up this case study too.
Yeah, no, definitely. I think in those situations, as you're waiting, and Rebecca can jump in as well, if there is no unassigned albuterol, your first response is to evaluate that patient and that student and call 911. I think.
Yes,
Yeah,
call 911. We have that coming in.
Always get on the phone with 911. And I feel very sad for those districts that don't have an unassigned albuterol, because it is a lifesaver, literally. And you should always continue to fight to have that for your district. But in the case where you don't, always get on the phone with 911, and they'll ask you what resources you have. If the student has their own inhaler, they may tell you, because we're looking at a label that says 2 puffs every 4 hours. They may say give 8 puffs, which you talked about before is equivalent to a nebulizer treatment. So they may tell you to do something that's outside of what you have orders for right there in front of you. But because they're acting on a standing order or some type of medical guidance from their own perspective, then they're giving you orders basically that a nurse can take. Also, we did talk a little bit about how this can quickly become critical. It is very important for every campus to have an emergency response team. It's very important to be prepared from this turning into its first a respiratory problem, and it will suddenly become a full-blown cardiac problem. It'll soon become a necessity for CPR and the AED. So be sure that your campus has a team that's prepared. If you're the nurse, you're the critical person to help coordinate that recruitment and training of a team. And if you're not the nurse for your campus, be sure that you know who is on that team, and be sure to volunteer to get that training so that you can participate in that.
Courtney, can you go to the next slide?
Oops. There we go.
So the response, Rebecca hit it on the head. The immediate assessment, pulse, breathing, responsiveness, start CPR, initiate 911, and hopefully we're seeing that. And this is part of you're thinking 2 and 3 steps ahead. You're thinking, okay, what am I going to do if this, and representing MedStar from a pediatric side, we've talked a lot about, it's okay for the medics to assess somebody. I think, you don't want to take that upon yourself, and having those extra set of eyeballs, that immediate transport that can get that patient to us in the ER is life-saving. So the time is of the essence at that point, and making a huge difference for somebody, and avoiding the situation and the response that we're ultimately having to do in this scenario where you're starting CPR, you're initiating all of that. But this could have potentially, I'm not going to say it was, but could have been prevented, right? We're always working the could have, should have, and I think this is one of those that we are more aggressive in the care as well. And then someone put in the chat, I saw Epi. So when you think about Epi, a long time ago, I used to use Epi, and that tells you how old I am, for asthma, and it's been something that we don't use anymore because we have so many other great medications that we can use initially. Now, if this is an attack related to an anaphylactic response, right? So this is you're in full-on anaphylaxis and you're wheezing in distress, Epi would be the most appropriate thing as well. And albuterol treatment as well can be helpful in that situation. But Epi related to an anaphylaxis event, yes. If we're not sure, then I think we stick to our guidelines. We call 911. We continue our short-acting bronchodilators in response to that treatment, and go from there. And so I think the next slide is questions, if anybody had some questions. Rebecca, anything else to add on this?
There was one I think I missed an opportunity. I wanted to tell people that when you're looking at the news in the morning, they will often tell you the air quality. But if you miss it, you can go to airnow.gov, or you can go to aircentraltexas.org, or there are a number of other sites you can go to check the air quality in the morning. If you're someone responsible to take groups out for recess or PE, you should know the air quality, because sometimes that'll affect how long a student with asthma can stay outside. You can get that on your computer. You can get that on your app. We did mention, or you and I talked, Dr. Guzman, about some school districts that have a flag system or a banner system where they post the air quality. It's that important to know, if you're taking a group of students outside, how long they can stay outside. I mean, we do have some red days here in Texas, which means that the air quality is, there's a lot of pollutants in the air, and it's dangerous for those with asthma. And one other thing is just to reiterate the importance of your school. I know I just said it, but just the importance of your school having an emergency plan in case you do have that worst case scenario where you have respiratory distress or cardiac respiratory/cardiac failure. And thank you so much for the presentation. It's
Dr. Guzman,
really a
we
great
do have
resource.
a couple of questions. I'm sorry. We do have a couple of questions as well as a couple of comments. The first question is, please discuss pulse ox versus peak flow in asthma exacerbation assessment. I have not received peak flow ranges in the asthma orders for years. Is one better than the other in determining severity of episodes? At what O2 sat would you want your patients sent home, and when to immediate medical care, to process immediate medical care?
All right. So I think all of them are helpful, but not absolute, right? So when you look at peak flows are going to be determined by a patient's weight or height and and their age. And so there are going to be some national averages that you can use. Obviously, each peak flow is going to be each patient's going to have their own set of numbers, and I think that's the important part. Having their healthcare provider help them, find their peak flow max, and then using that as a guideline, right? When you have to do that. Now, we talked about this. There's not a lot of people doing peak flows anymore. I think they can be helpful, and maybe we need to start to revisit that in some of these. And the severe patient, obviously, you're going to be able to tell for the most part, but it can still be a good adjunct. Pulse ox is also a good adjunct. I find that they're getting better and better if you buy them over the counter. But they're still not great. And I think you're using that piece of information with all the other things, all the other cues that are part of an assessment. And that's what I tell parents when they come in and say that their pulse ox meter at home was reading 78% on their 8-year-old. And we talk about, and that may be that was the only thing that was off, maybe a little bit of a cough, and they had some URI symptoms, that it's an adjunct to what's going on. So again, if you're using that plus your assessment skills, and you're seeing that, this patient does have an 88% sat, and they're a little bit they have a little bit of work of breathing, they're coughing, they have a little bit of wheeze, then I think that together would then push me to say, all right, they need to be obviously treated, or maybe assessed in the ER or by their PCP in the end. Did that answer all the
Thank you, Dr.
parts and
Guzman.
others?
The second question is, if the student or parent does not provide a spacer, do you recommend the clinic provide disposable spacers for students?
I'm always about providing tools. I think if we can find, if someone doesn't have the tool, obviously reaching out to the family and finding ways to help them. But if they can't have that, then having that in the clinic or in the school setting, there's lots of things that need to happen to be able to make something like that happen. We give out gun safes and gun locks all the time, and I think this would be no different in providing the tools. And I think this is an important tool, right? I mean, you saw the little graph and how much, and I know this from just taking care of kids, that MDI does not achieve what we want without a spacer. It really does not, and it causes obviously our young kids and all of our kids and even adults to have more exacerbations likely than we could prevent if we had a spacer associated. So I would advocate for that. There's lots of discussions on how we can get that done and provide some of that, and Courtney and Marquita we can kind of address and see what we can do to help in those situations if that's not already happening.
Okay, thank you. I also have a couple of comments from Liz Barito, who is one of our asthma educators here at Cook Children's. She said that there are at least 6 different albuterol inhalers out there, and they are different colors. Some have brand names like Ventolin or Provenal, but they all will also include the generic name, albuterol sulfate. Reading labels is so important. Also, some inhaled steroid inhalers are the same color as the albuterol inhalers. So reading the labels is very important.
Definitely agree.
Mhm. I also have a comment. Sports is after school hours where I am, and nurses are no longer on campus. Having clear plans and training of staff that are overseeing the practice is important to administer the medication, inform guardians, and call in 911.
And I would ask if Rebecca had any comments or thoughts around that, in working with folks outside of the traditional school hours and talking about that emergency response team. And thoughts
For
on.
our district, we have what's called a self-administration order, or basically a self-carry order. So a lot of our students who are there before and after school, especially for athletics and things like that, have a way to carry their inhalers with them. And so I do encourage districts to make sure that you have that, because yes, we have a certain limited number of hours that the nurse is actually there. But just like we talked about before, having the asthma action plan and communicating it, making sure that the student knows how to properly use it and is not necessarily just pulling it out every couple of minutes, that kind of thing, definitely falls on, it would be helpful for the nurse to provide education for that scenario for those students that fall into that. Now that we do have students even in the second and third grade who are trying to self-carry, and that's one that worries me a little bit, because a lot of times those are the students who don't necessarily have the proper technique, or who don't necessarily have the skill to keep up with it. So I would say that, we just have to look at it as a district and as a campus, making sure that we sit down and talk about those that fall outside the norm. Those are the students that would need it outside of the school hours, or need it more often than other students. It becomes a challenge, but definitely something that we have experience in and we can solve.
I would even advocate for, in-service days, when all the teachers are there and coaches prior, maybe even before the school year starts, to have these discussions about these types of scenarios and what to look for, and just kind of provide and equip those around y'all who are not taking, aren't the school nurse, some guidelines and keys on how to do this in school as well as out of school. So I think that would be an opportunity where you can grab everybody potentially.
Okay, we have one last comment. In a rural school where it takes 15 to 20 minutes for EMS to reach us, assuming an ambulance is available, it is so important to call as soon as your spidey senses tingle. Thank you, Allison Walker.
Agreed.
I love that. Yep. Spidey senses will save a life.
Well, just like Dr. Guzman said, if your principal gives you 5 minutes in a meeting, be sure to take advantage of it. Never say, oh, no, I don't need to meet with anybody this week. Just be sure. You can always review these type of signs and symptoms, review your emergency action plan, etc.
Yeah, and just provide that reminder for the, those outside of the normal times of coaches and, practices, that, if you see something, like anything else, you see something, say something, right? Like, oh, I see Johnny or Joan who's using their inhaler a lot. Maybe I should talk to Rebecca and let her know that this is going on after school.
This is also great. Thank you so much, Dr. Guzman and Rebecca, for sharing this information and bringing in those joint perspectives to help our school settings come up with their own robust plan for addressing asthma emergencies. And thank you for all of you who have joined us on the call today. We have a couple items left that we'd like to share with you before we close out. I'd like to invite our partner with Asthma 411, Dr. Leslie Alsop, to come on camera while I introduce her. We work with her with the Asthma 411 initiative in Tarrant County in North Texas. So some of you are participants in that with all of us there. It's why we bring this in service to school health staff every year. And she's going to share a couple updates for us on that program.
Wonderful. Thank you so much, Courtney, and to everyone who's made this possible, our planners, presenters, and participants who have given your time today, so together we can help children be safe and breathe easy at school. I'm going to just take a minute to give a few updates, both about our greater Tarrant area, but also our new North Texas Asthma Coalition and some asthma initiatives and updates at the state level. Next slide, please. So we've talked a little bit about Asthma 411 and the mention of unassigned albuterol. And I know we have some participants from outside our area. I just want to say a couple of words about what that model is. And it actually was first developed nearly 20 years ago, not long after the National Heart, Lung, and Blood Institute first came out with guidelines for comprehensive school asthma services. The CDC wanted to support some demonstrations of what those school asthma services could look like within coordinated school health. And one of their awards went to Dr. David Sterling, who was then in St. Louis. And that was where the Asthma 411 program began. He got to work with his academic partners, community partners with health systems and clinics in the area and schools. Now, it was comprehensive support. School nurses let them know one of the real barriers was to prepare for those emergencies and make sure quick relief medication would be available, and that if they could have standing delegation orders that really and stock that albuterol on the campus, it would be a big benefit. So they went ahead and did that. Along with that comprehensive support, the community partnership, the evaluation indicated improved asthma outcomes, and we've been working with that ever since. Please, next slide. So today, we are so delighted to be able to have our partnership with Cook Children's, UNT Health Science Center, Safer Care, and JPS with over 350 campuses. And just some numbers from last year, there were 1,476 reported uses of unassigned albuterol for children, for students thought to be experiencing respiratory distress, and about 75% of them were able to return and complete their school day. About 25% dismissed to their caregiver or parent. Again, not just to go home, but for that critical consultation about what the student's needs are to be safe and healthy, often to get same-day care. Next slide, please. These are some of our key findings, and if you're interested, we'll be posting this on the Asthma 411 website. Again, about 3/4 of the kiddos in our program last year were able to return to class, and we can estimate about over 4,300 reclaimed instructional hours, some substantial saving to schools and to parents by reducing school and work-related absences. Nurses overwhelmingly thought it was manageable to implement, and a whole lot of the unassigned albuterol being used reported in the state is occurring in our region, largely because I think our partnership has really been so important to supporting schools and making it possible. Next slide, please. So we can break this down just in case anybody's interested. Again, I think these types of numbers are really important for helping get administrative support and community support for these types of programs and for school health services and asthma services in particular. Next slide, please. I do want people to know that North Central Texas has relaunched its Asthma Coalition, and in June we'll be holding a second annual North Texas Asthma Summit on the power partnerships to try and improve asthma outcomes for all children in North Central Texas. Next month we are due to have our first quarterly newsletter so that we can have information about resources and training events across the North Central Texas area. We have a number of wonderful institutions who are involved, and if you would like to get more information, please feel free to send me an email or Courtney an email. Children's, of course, is very, very much involved in supporting and leading this forward. Next slide. Also want to provide just a couple of updates at the state level to make sure everyone knows that the Texas Association of School Boards has issued updated guidance on unassigned albuterol, so that now their policy recommendations do align with the 23 legislation within this Texas School Health Program. updated administrative code is due out next month, and we're putting together implementation guides and unlicensed personnel training in collaboration. So 23-24 annual report is also there online. I also want to make sure one last opportunity to get involved. The Texas Asthma Control Collaborative is available and has a school health work group with that goal of, again, improving asthma outcomes for all Texans. Anybody with an interest in improving asthma management is welcome to join, and there is a membership form. I may ask Courtney or one of our hosts to see if they might put that link into the chat. And that's all for me. Thank you all so much. Next slide would have my email on it in case anyone is interested.
Thank you so much, Leslie.
Thank you.
This is great information. And for those who were asking earlier, yes, all of these slides and materials will be available online. So we'll be sure you have everyone's contact information and links after this event, and you'll get that by email. I'm going to hand it over to Marquita Jones, who is our program coordinator for Community Asthma Initiatives at the Center for Community Health. You've heard her voice throughout the service today, so I'll let her close us out. Marquita.
Thank you, Courtney. Thank you, Dr. Alsop. Thank you, Dr. Guzman and Rebecca, for your wonderful presentations. And thank you all for attending and engaging with us today. We want to make sure that you have your information about the continuing education CE. I would also like to thank all of the active participants in the Asthma 411 program, as well as all the ISDs, teachers, coaches, and administrators that joined us today. As a reminder, please check your email in the coming days for the event evaluation, which is also a way to receive your CEs. The email will come from Jean Hostler. Today's recording and link to CEs will be posted online at cookchildrenscommunity.org in the coming weeks. We will notify you when that is available. Please share with your colleagues that could not be here today. And for those who are unable to attend, if you would like to receive free CEs, they can watch the recording and complete the evaluation by the end of 2025. The details that will be listed in our following emails. So watch out for that email. Again, thank you and your staff for making it easy to serve you. And also with that, thank you all for joining us today. And we hope that you have a great afternoon.